for our project is about timing of no-code patient admitted to ICU. Our team, Dr. Yasin, Dr. Hassan Dorzi, and Dr. Farhan Anizi, Dr. Sajid, Dr. Musharraf, and Mrs. Filwa bin Hamid, and Mrs. Widian. Thanks for all the team. And our background, as you know, CPR is one of the essential pillars in health service, but we don't have data in Saudi Arabia, so we are limited. Our objective try to compare the outcome of and length of stay in the ICU who's with the non-code status versus full code. The method, it was conducted in the King Abdulaziz Medical City National Guard Hospital, and ethical consideration IRB approval was obtained from the review board, and patient confidentiality was maintained. The including criteria for this research, it's about all ICU patients admitted in 1999 to 2017. And the excluding criteria was a readmission within 48 hours, or brain dead or brain patient. The methodology of this research, it's retrospective SHAR review of collected data from ICU database of non-code status, and the data extracted from secure database in the intensive care unit, which is maintained in data collected from 1999 respectively. So our comparison with baseline characteristic of non-code patient, we found the age more in non-code, which makes sense to have a patient more older. Male gender is more also in non-code patient. Also, regarding the admission category, we have around 53% of the admission of the non-code patient, they are cardiac, and also they are diabetes, cirrhosis, and 82 from them, they are mechanically ventilated. Regarding the respiratory issue, we found no difference between the full code and non-code patient. So for the chronic disease, so chronic liver disease and chronic renal and chronic cardiovascular, they are almost in the non-code status, they are very significant. And regarding the laboratory finding in first 24 hours, all the parameter that's measured in the first 24 hours was more high in the non-code status, which makes sense because they are the most sickest for the non-code status. For outcome of non-code patient versus full code, we found the mechanical ventilation more in the non-code status and tracheostomy. Also, renal replacement therapy, ICU mortality is around 67 in non-code status. Also, the hospital mortality is 82 for non-code status. That means around 18% of the patient, they are, by the way, hospital mortality here involve ICU mortality and floor mortality. So the 82 of them, they have hospital mortality. That means 18% of the patient, they are discharged from the hospital or transferred to another hospital. So ICU length of stay is more in the non-code, and timing of no code, it's always same between the two groups. For the just this is performance status, we add the performance status to be compared between non-code and full code, who's at risk for or to be labeled non-code from 0 to able to carry without any limitation or restriction for his movement, or 5 that's who's dead, and vice versa. So in this table about the performance status, that's indicate the non-code status was more common in patients with lower functional status as baseline. And the predictor of non-code patient, we found the age and Apache is more with odds ratio more than 1. That's predictor for non-code patient. And also the ranking score for if we compare it by 0, that's mean 1 is more than 0, 3 more than 0. That's increasing by number of the modified risk factor. This is the just graph. We show the full code versus no code admission, which show decrease the non-code admission within the period. Maybe that's I think that's the cause because we improved the management and improved the modalities of the treatment. Also, the last thing was about hospital mortality, that decreased the hospital mortality of non-code and also full code during the offered decades and period from 2005 to 2017. This is my talk, and thank you.
Thank you, Dr. Abdurrahman. So what you're going to write in this case? So what are the main messages from this project? What are your main take-home messages?
We have the main message to know the main message to level of the care is important before reaching to the ICU. I mean, not all patients need to be determine the level of care while in the ICU, maybe to determine the level of care that before. And the second thing, if we have a patient who has risky or have advanced disease, we like chronic cardiovascular age and Apache, I think we should discuss the, as we said, level of intervention we can do it, like CPR, intubation, and others.
Good. I think there are a few also direct messages. If you can go back a couple of slides, I think you should highlight them in the discussion, very important points.
Yeah.
Go back. So first thing, before we talk about difference in age and etc., out of 24,000, which is really large sample size, صح؟
Yeah.
خليها active. Out of 24,000 patients, 3,000 were no code. So that's like 15%.
Yeah, around that. Yeah.
Around 15% or something like that. So you need to calculate this. So about there are 15% of patients in general were made no code in the ICU among the admissions. And this percentage has changed over the years. This is the slide. Can you go to the other one with the graph?
Yeah.
So 15 if you take all the years. But if you take over time, it's actually in the early years, it was around 20%.
And decreased
1999 until 2008. Then it decreased to less than 10%.
Yeah.
Now, there are many interpretations for this, the reduction. One of them, you said improved care. Yeah, maybe possible. Second could be, you could see the number of admission increased a lot.
Yeah, that will affect for, percentage. That will affect.
Yeah, so I think in the early years, we didn't have many beds in the ICU. So the one who make it the ICU are really, they're very advanced. While when you have enough beds, you may admit patients who earlier stage, so they are more salvageable. So this may also explain the drop. So that's another explanation, which is very important. And that explained the next slide, which showing mortality is reducing among the no code.
Yeah.
So this, you have to find an explanation for the reduction of the mortality among the no code. So the other thing is no code doesn't mean death.
Yeah, doesn't mean death. Maybe discharge patient.
Yeah, is that correct?
Yeah. Maybe discharge the patient.
How much are discharged home?
Around 18% from non-code patient.
Correct. So you have to highlight this point.
Yeah.
And that also changed over time, because here, I don't know, this percentage mortality of the no code. So if that's, this one, we need to look at this numbers here, because if it's 80% overall, this slide doesn't reflect it.
80% of mean of non-code patients.
What's this line here? Line reflect what?
Mortality of non-code.
Yeah, so mortality of no code was 60%, then dropped to 30. So cannot be the average 80%, not possible, right?
Yeah, it's not. Maybe I will ask Dr. Musharraf about that, because he's.
The slide need to be looked at.
Yeah.
But it will be interesting to see difference in time. There's another point which, go back to the other slide. You highlighted in your title the timing of no code, and I think that's important.
Yeah.
So timing, no,
Yeah.
Looks like on average, we make patient no code on day 3, but sometimes up to day 10. So typically we give patient a few days in the ICU before they are decided about no code. That's important.
Yeah.
The other slide about the functional status is just beautiful. It's amazing. Actually, this, if I am in the journal, I will take the paper because of this. Go back to the next slide. Next, this one. It's really very nice. So as you go down with the lower functional status, much more likely to patient to be made no code. So looks like clearly physician take in consideration the functional status of patient. So if the patient functional status 5, this is the highest likelihood of getting no code compared to others. And you could see it increases each time it increases, it goes up 1.2, 1.4, 0.6, 2.4, and then jumps to 7.2. Very nice comments from the group. Dr. Hani تمساح تفضل دكتور هاني.
السلام عليكم. يعطيك العافية عبد الرحمن. Very interesting result. I'm from the pediatric ICU background. However, we have, you can hear me well, Prof. Yassin and colleagues? Yes. So really amazing. But the issue, as you mentioned during the discussion, remember that any changes you see over time, it's multifactorial. So yes, we could be advancing in care, but however, we have to keep in mind that it's multifactorial. Something that you may add a flavor if we can calculate. Did we check about the length of stay in the hospital? I missed that one, perhaps, because that could give the flavor of the financial cost, the reduction in the. And I know one colleague who can do from the what do you call health, not informatics, health economics. They can estimate for you how much is the savings for each group, the no code versus the full code groups. So that you may consider to add some flavor, because always we talk in the no code ethical principles is the justice that you wanna also patients who should be no code status, or that you wanna make justice for the community to keep the resources for those who needs it, or those during the crisis who needs it. And probably we have seen a rise of the no code usage during the COVID crisis. And I think that's documented in the literature also. So that's the only issue I could add, and wonderful work, Hakeem. Thank you very much.
So comment on this one, Abdurrahman. This is a very important comment.
Yeah,
and you need to address it adequately in the discussion. Go back to that table. This is very important.
Yeah, the length of stay, you mean?
Yes, the length of stay.
That's economic effect.
No, before the economic effect, describe the effect on length of stay.
Yeah, length of stay for the hospital ICU length of stay, it's 6.3 for non-COVID, which that's mean they are using more resources while they are not COVID patient versus the full COVID patient. And also hospital length of stay 16 days for non-COVID patient. Which is more in full code. That's more makes sense.
So what we are seeing here, you need to look what other studies showing. It's really very interesting. So the ICU length of stay is longer in the no-code patients, but the hospital length of stay is shorter. ICU length of stay is longer, hospital length of stay is shorter. طبعا part of this issue is that 80% of the patient die. ICU die in the ICU 67%. So about 70% die in the ICU. I think that's the explanation. There are a lot of patients die in the ICU, so the length of stay in the hospital will be
less.
Beyond the ICU will be 0. Beyond the ICU. So
yeah.
You could create another variable called post ICU length of stay, for example.
Yeah, hospital stay as part of hospital stay.
Yeah, to understand this a little bit better.
Or perhaps, yeah, if it could be post code status. I don't know whether Prof, because it's after the code status is decided, then the length of stay, it's like a reset button. Isn't it, Prof?
Yeah, that's another way of doing it. Or looking at the length of stay in survivors. Because, I mean, here, this is the length of stay in the hospital is shorter, I think because of death. That's why.
In ICU, yeah, most of them, they are death in ICU.
Interesting. So economically, I don't know what you expect, Dr. Hani. It will be, I mean, to look at economic, it will require some statistics. I know.
There are some estimates from one colleague about the ICU economic estimates from the MOH. One colleague calculates it through the MOH data sources, and there is for the hospital. So that's one way to, but maybe that's another subgroup, or I think if he's ready to write it, I think it's wonderful as is. So not to, but that's something to keep in mind. Maybe in another study, Abdurrahman, you can consider it. That's something you may have.
Yes.
Okay.
Very good. Excellent. Any other comments? Raise hands. We have Dr. Iman Ahmed and then Dr. Saleh Sheri. Dr. Iman first.
Assalamu alaikum jami'an.
Assalamu alaikum.
Good evening, Prof. Ahlan, Dr. Abdurrahman. Unfortunately, I missed the lecture in the beginning. My question is, in your study, what was the reason? I mean, you were able to identify the reason for admission for these no-code patients?
Yeah, most of them, they admitted as cardiovascular.
Mm-hmm. And these two graphs, which shows the percentage of the mortality and the percentage of the no code in relation to the whole, I mean, what's the percentage of mortality in relation to the no code?
Oh, we can, I think we should subgroup for that from no code. You mean no code patient, the mortality?
Yes, I mean, how much the percent? Because you have two tables.
Yeah, no code patient, the mortality is 82 inside the hospital. And that's mean 18% of them, they discharge from the hospital. Especially this is a high center, so mostly they are not transferred to other hospital. If we exclude the transfer to other hospital, 18% from the ICU, from the patient non-code, they are discharged to home.
Okay. And maybe one thing regarding also this showing that in 1999 we have the concept of no code. I was a bit astonished that at that time we have this concept of no code.
Yes, we have it. We have no code policy in National Guard since 1995.
Okay.
So it was there.
Okay, thank you.
Thank you.
Yes, thank you. Dr. Saleh Sheri. So that's another point, as a good point to remind us, Dr. Iman, we should say this in your setting, that there was a no-code policy in the National Guard, at least from 1995. I remember, definitely when 1999, there was policy. I think it started in 1995.
Okay.
Dr. Saleh.
Assalamu alaikum.
Assalamu
alaikum.
I am pediatric intensivist. Thank you very much for this nice project. The utility of the no-code status in the ICU, I would fragment the data to pre-ICU admission and post-ICU admission in terms of timing of the no-code. I mean, what is the time the patient got no-code? Did he got no-code in he signed no code pre-ICU admission or post-ICU admission? So that makes difference in terms of, if the patient to start with was out of ICU, and then the patient post signing him no code admitted to the ICU, mean the no code status has not limited the, the abuse of the ICU. This patient might be shifted to a palliative care room rather than dying in the ICU if he's expected to die. So my question is, no code status, do we know their timing of the timing of signing them non-code? Is it pre-ICU or inside the ICU?
What I know, it's before we not admit any patient in ICU if they are not code, unless they are for BiPAP. But most of the patients, they are no code after they admitted to ICU. It's not before.
Excellent point, Dr. Saleh. And this is important, Abdurrahman, to put in your paper, that according to our no-code policy, patients who are no-code are not admitted to ICU.
Yeah.
Patient on the ward, it's rare exception that we admit, but generally the rule, if somebody labeled no-code, this means no admission to ICU.
Okay, so that's lead to me to the second question. If no code, I would identify their first of no code status, whether any of them, because their mortality rate show at certain time they are less than code status, full code status. Maybe their no code has been revised, so maybe they had some escalation to somewhat of the support. So also that need to be indicated. Why they've shown good improvement in the mortality? Maybe because of some escalation of the care or revision of the no code status.
Or it's increase the number of the patient. 1995 or 1999, it's the number of admission around 3,000 of ICU admission for fully. Now it's increased with the time that will cause. But regarding the I not mention any patient outside the admitted, died outside the ICU, non-code in ICU and he not admitted to ICU. The first should be included in ICU patient admitted by ICU before. And then we'll decide to discharge him from ICU and to measure the mortality in the hospital.
Some center, I don't know, King Abdulaziz Medical City, if they are doing, some non-invasive support in palliative care outside the ICU. So maybe some of these no-code status have received some non-invasive support. So that's why their mortality rate is comparable or better than expected. So, sometimes practically when we are admitting patient who's no code, there is negotiation about the level of support in terms of escalation and limited escalation. Thank you very much.
Okay.
Excellent point. I think this is a really good point from Dr. Saleh. You should also mention it that according to the policy, no code can be reversed. We have reverse of no code, as Dr. Saleh mentioned. And but in your study included only patients who had no code and not reversed. The non-reversed are considered as full code.
Yeah.
In this analysis.
Yeah.
And BiPAP as palliative is allowed by the can be used as palliative. But these are really good points. Very good. Excellent discussion. So please take notes of these, Abdurrahman. I think they will be useful for you to address. There are lots of comments. And thank you very much. I think because of time, we need to move on.
Thank you.
Thank you, Dr. Abdurrahman, and all the best in your training. Stay with us, and if you have comments on the other projects.
No problem.
So next presentation will be by Dr. Salim Wadani, going to present his project on prevalence and outcome of AKI in cirrhotic patients. Dr. Salim.
Assalamu alaikum. Can you hear me both?
Assalam wa rahmatullahi wa barakatuh.
Okay. So how can I share the screen? Not share it.
Rose, can you make him a co-host?
No, I'm co-host. I will share the screen. Okay. You can see screen both.
Yes.
Sorry, my laptop in Arabic, so it took it from right to left. I couldn't change it from the left to right. So starting from here, first of all, my name is Samuel Dani. I'm an assistant in Singapore Business University. My project is about prevalence and outcomes of acute kidney injury for patients who are admitted to intensive care unit. Still in progress, but almost 80% of the project. So starting with the abstract, this is my research manuscript. So starting with the abstract, starting with the background, generally speaking about liver cirrhosis. Should I go through the background and introduction book, or just?
I think you should go through the points that worth discussion and get input from people. I don't think the background is important now. So the main findings, main messages, this kind of thing.
Okay. So first of all, my project is a retrospective cohort study, studying liver cirrhosis patients who are critically ill admitted to intensive care unit over 15 years time. We had total of 1,197 patients. The study population mainly adults who are aged more than 18 years old. We exclude patients who are known to have end-stage renal disease or ongoing dialysis. This is the main exclusion criteria. In terms of, we estimate the serum creatinine as baseline, because some patients we don't have their baseline. So we use the MDRD formula using the determined value here of 17 ml per minute. Data was extracted from our database. So we had total of 1,197 patients were found eligible to be included in the study. Females were representing 43.3% of our patients. I will show it in table. It will be better. So in terms of baseline characteristics of our patients, so total of 1,197 patients. We group them into 4 groups: no AKI, stage 1 and stage 2 and stage 3 AKI. Age, the median age of no AKI group was 60. For the stage 1, 65, stage 2, 63, and stage 3, 64. And it showed that patients who are older, they are more prone to have AKI with p-value less than it was significant p-value. In terms of female or male, it wasn't significant. For the body mass index, it was significant. Patients who had AKI, they have more BMI, with the median 29 in stage 3 AKI versus 25 in no AKI group. This is the main slide for the most common comorbidities was found cardiac, and it was significant patients with cardiovascular cardiac disease. They are more prone to have acute kidney injury. So in terms of primary outcome shown in this table, you can see the table clearly.
Yes.
Yeah, okay. In terms of hospital mortality, showed that patients with acute kidney injury, they have more hospital mortality. This is a univariate analysis. In terms also of ICU mortality, the highest was stage 3 acute kidney injury group. It was 53%. For the ICU length of stay, it was also significant. For the mechanical ventilation duration, it was also significant. However, in survivors, it wasn't significant. And of course, renal replacement therapy, patients have advanced kidney, they will have the high percentage to have renal replacement therapy. It was almost 49% in stage 3 acute kidney injury. Also, we did surprising that we did multivariate analysis in terms of comparing stage 1 AKI with no AKI and stage 2 with no AKI and stage 3 with no AKI. It showed that no mortality difference between patient who had AKI acute kidney injury versus patient who had no AKI, no acute kidney injury. However, the factor that increased the mortality was age, that for and vasopressors use, they will have higher mortality, and also ABS score and bilirubin.
So I think this is important table here. So how do you explain this? There is AKI and crude analysis, there is an increased mortality. On multivariate does not appear to be associated with mortality. Any possible explanation?
Yes. So, and the first one, the univariate analysis, it has a lot of co-founders. Patients might be sicker, they might be older as well.
Yeah.
They are older and they are sicker according to the ABS score. However, with this multivariate analysis, showed isolated these compounder and comparing both for stage 1 and no AKI group, some insignificant.
So that's definitely an explanation that confounders, يعني مثلا requiring vasopressors, having high bilirubin, these are cirrhotic patients which reflect liver disease, lactic acid, age, really more important. There's another factor which we really should have paid attention to it, which is the APS score. APS score already have creatinine and has acute kidney injury. In fact, you get double points if you have acute kidney injury. And the APS is significant. So it's possible this lack of statistical significance because we included the APS and AKI. We should probably have removed API. I don't know. So so the lack of clinical significance here doesn't mean really that it's not important because we included APS. Maybe we should do this analysis without APS and see what happens.
Okay. So to speak about the outcome, this section there is about mainly about the limitation, and the step I need to write more about the results. And so one of the limitation when you compare to the literature, our cirrhotic patients have higher mortality. In the literature it's around 43, while our patients were 57%. But this factor, because we have different population, our population they have the most common cause is viral hepatitis versus alcohol with population. This one explanation. The other explanation, all our patients they were admitted to ICU. That means they are sicker and they have higher ABS score. This is one of the explanation of the mortality rate in our population. Also, one of the limitation is that we use in case we don't we use estimated formula. if we don't have the baseline creatinine, which might it might presume that some patient who has no AKI might have stage 1 AKI, and patient with AKI stage 1 or 2, they might fall into stage 3 acute kidney injury. This is the main things and the discussion part.
What other main important messages from the paper? Can you go back to the previous tables?
So the main message.
The other tables.
Okay.
What other messages? خلي هذا good. This outcomes.
Okay. The main message that we know that having older age and BMI, higher BMI, and use of vasopressor and higher bilirubin all are contributing to increase the mortality on those patients.
Yeah. So I think you should say an AKI is very, very common among these patients. More than half of them have AKI.
Yes.
Of one stage or the other. صح? So very, very common. And more crude mortality is high. And even no matter what you look at it, like stage 3, 72%, 2/3 of the patients died, which is very high. Is there another explanation for the high mortality other than hepatitis C, which is important one, but any other reason?
Other than our population with all in ICU, that means they are more sick than hospital population, general speaking. So it is all of them.
If you compare it to study coming from Canada or US, they will probably report 30% mortality. Here are reporting 50, 60, 70%.
Yes.
What's the reason the mortality is higher here?
I'm not sure about how to answer this question. Other than I was thinking of that the population is sicker and the cause of
sicker. I think it's really related to the discussion in the previous presentation. موضوع الcode status. I think we admit to our ICU patients. In other places, they don't admit. They will be made no code before ICU. So you are admitting sicker patients, so your mortality is higher. I mean, this is what we see in practice. صح, Salim?
Yes.
We admit patients who, this patient should have been no code, but for many reasons, they end up in the ICU. So just increase your numbers. Fantastic. So any other comments, or we'll open it for discussion? Maybe comments from the group? How we can, thoughts, comments, Dr. Salim? Dr. Saleh, تفضل.
يعطيكم العافية. I'm enjoying the discussion. I think, Prof, timing of replacement, timing of the renal replacement therapy and duration. This type of patient tends to take long time for the CRRT. So whether the duration is shorter in some patients might be because of the level of acuity, or code status has been initiated at one stage.
Duration of the CRRT?
And timing, whether they got early or has been started late.
Is a good point. I think should address it, Sanem, this is important. In the database, we don't have this data, so maybe this will be one of the limitations. We don't have detailed data about timing of renal replacement therapy or duration.
Yeah.
But we have how many patients received it, which is, it is there. So
and during this time, do you have certain groups that were ended by having liver transplant? Some cohort of this group?
Salim?
So you mean patients had the liver transplant?
Sometimes with the CRT, but they got, got recovered or got a good outcome because they've been transplanted during that admission.
Yeah, good question, Salim. And also should be addressed in the paper.
Yes, yes. I will look for it if the patient had liver transplant or not. It's a good point to add.
I think we should address that in the methods. Generally, in our hospital patient, and actually generally, the policy for patients who admitted with acute decompensation of liver disease, they don't transplant them acutely. So most of the transplants are for kind of elective cases. I don't know if that addressed your point.
Sure.
Any other comments? We have another raised hand, Dr. Iman.
Yes, Assalamu alaikum again. Just I would like to know, this was a case control study or what type of study?
Retrospective cohort study.
Because I think you showed one table about odds ratio. Can you please just show this table again? Yeah, this is the odds ratio.
Yeah.
So
It's a cohort
And,
study.
what?
Yeah, it's not the relative risk. I mean, if you have cohort study, usually you will go with the relative risk.
The odds ratio probably better.
And here, what I see in this chronic cardiac, it seems a bit protective, I can say. It's 0.59.
Yes, it's odd, but that's, yes, true.
So why it's in chronic, they were less?
Salim, any thoughts about this one? It's a very good point.
This one, I'm not sure what I have estimated but in univariate variate analysis, the previous one, it showed it's actually increasing the mortality.
Yes, a very good point. I think when you adjust for multiple variables, some of them may be collinear, or it's definitely a good observation. Very good observation. Doesn't have very good explanation biologically.
And one more question, Prof, regarding the BMI. I mean, these patients are cirrhotic, they have ascites. So, I mean, how can you relate this to the actual body weight, or is it the severity of the disease?
Yeah. This is a problem with BMI always. So BMI, fully agree with you. And a good point to address also, Salim, in your paper.
Yeah.
So BMI in stage 3, 29, مو معناتها no more obese. I agree with Dr. Iman. Maybe they are more fluid, more ascites. You got my point?
Yes, it's very clear.
So this actually, these patients, when they are more advanced, they are more debilitated.
Yeah,
Their muscle is depleted, but they be more edematous. So the BMI here, يعني BMI technically really doesn't reflect the fat mass here. I don't know. Agree with you.
Thank you, Prof. Really, we appreciate really these sessions and good study, but unfortunately the voice was not very clear. And if you kindly, when you mention something on the table, if there is a way you can show where you are, just which column you are indicating, because sometimes it's not easy to follow. Good job. Thank you very much.
Thank you, Doctora, very much. Thank you. Thank you, Dr. Salim. And next is Dr. Abdul Majid Mtairi going to present on AKI in patients with community-acquired pneumonia. So similar theme, but there's different population, acute in community-acquired pneumonia. Dr. Majid? But and just take the notes about the voice, or maybe come closer to
Yes, Assalamu alaikum.
microphone. Welcome salam. Yeah.
Yeah, the voice is clear.
Good for me. Yes.
Okay. Assalamu alaikum. My name is Abdelmajid Amtairi, ICU resident R4. I'll be speaking about the project of prevalence of acute kidney injury in patients with community-acquired pneumonia who require mechanical ventilation. There are a few studies focusing on these groups, and that's why we were interested on doing the project. Just go through a little bit of introduction. I spoke about, wrote about the community-acquired pneumonia and how common it is worldwide. It's associated with high morbidity, high mortality. It requires a lot of like 25% of hospitalizations by CAP. I also spoke about the geographic prevalence around the world. Also in Saudi Arabia with 13% prevalence of CAP itself. And then I spoke about the acute kidney injury, the frequency, the frequent complication on CAP patients, and multiple studies. It shows that it's ranging between 18 to 34%. All CAP patients develop AKI. These studies actually including all CAP patients, not just the ventilated patients, all admitted patients to the hospital, ward patients, ICU patients, ER patients. So it's like a big group. And then I spoke about why it's important to recognize AKI in critically ill patients. There is also a lack of data on health risk factors on the geriatric patients. Older patients are more common to have CAP as well as infection, and those also with diabetes. So the risk factor with patients with diabetes, older age are more common or more prone to have community-acquired pneumonia, which is most of the CAP patients are with these comorbidities. I also shortly spoke about the mechanical ventilation itself as a support in the ICU, and there are studies, and it's well recognized that there is a ventilator itself induced kidney injury, and most of these CAP patients will end up in the ICU requiring mechanical ventilation, and preventive therapeutic options are limited on these settings. So because of these such combined factors and the existence of many other comorbidities, people, or elderly people especially, are at high risk of developing AKI. And then I went through some literature review. As I said earlier, most of the studies are focusing on the CAP patient, the whole CAP patients, ICU, non-ICU. And then the objects of my study is to evaluate the prevalence of AKI in mechanically ventilated CAP patient and whether AKI development is associated with worse outcome. I designed my script as I started with method and materials, design and settings. So it was a single center retrospective cohort study conducted in the intensive care department of King Abdulaziz Medical City National Guard in Riyadh, Saudi Arabia. It was approved by institutional board review. Then I spoke about the center, or the King Abdulaziz Medical City, which started with 1 ICU during the study and progressed to be 9 ICU. All this happened during the study itself. And it was, it has round-the-clock consultants, ICU, nephrology, internal medicine, radiology services, with ICU consultants being on site all the time, with fully staffed middle grade fellows and residents covering the ICU at the same time. The study population where all patients who aged above 18 are admitted with CAP and require mechanical ventilation from the 2002 until 2017. We excluded all patients who developed pneumonia 48 hours after admission or has history of end renal stage dialysis requiring dialysis. We defined CAP and AKI. CAP was defined as any sign of lower respiratory tract infection with chest infiltrate on X-ray. Although we did not use this, the definition itself, but clinically we're going with the same definitions as it is defined, but the diagnosis was clinically most of the time. And then AKI was according to the KDIGO criteria. We'll just go. Then I spoke about the data collection, how it was collected. Prospectively by full-time data collectors. It includes all of the demographic variable, age, gender, history, chronic disease. And then I wrote a little bit about the statistical analysis. And then the results. First, we started with the patient characteristics. We had 1,536 patients were admitted to the ICU with CAP requiring mechanical ventilation. 54% of those had no AKI, while 46 had AKI, which is almost 50% of those who got intubated developed AKI. And with different stages, stage 1 and stage 2 and stage 3. We'll go to the tables to show it better. So here we have the characteristics, patient characteristics. We had 1,536 patients. Around 830 had no AKI, and the rest, 40-something% had AKI stage 1, stage 2, stage 3. What interestingly was found here that diabetes was one of the common on patients who develop AKI and male gender. Also the age, elder age are prone to develop AKI. And then some about admission category, medical, 90%, 98% of them had medical issues. We also found that higher vasopressor were found on the stage, and the late stage of AKI had used higher doses of vasopressors. The PO2 FiO ratio was lower in those stage 2, stage 3. And creatinine, as per the stages, it's going up with the stages from stage no AKI to stage 3. Then we go back to we spoke about the patient characteristics like quickly. Primary outcome was hospital mortality and ICU mortality. 40% died during the hospital stay and 26% died in the ICU. Hospital mortality was, of course, higher in the AKI group compared to the non-AKI. Secondary outcome was ICU mortality, higher in AKI patient with 38% in stage 3 compared to 20% on no AKI. We also spoke the length of stay, mechanical ventilation, durations among the survivor and those who died. We can show it on the tables for a better. So hospital mortality was 40% among all patients, 34% on the non-AKI, and around 67% for those who had AKI, 38% on the stage 1, 40% stage 2, 51 on stage 3 AKI. ICU mortality, again, higher on the stage 3 and lowest on the non-AKI group. ICU length of stay was highest or almost the same between no AKI and stage 1. Stage 2 was shorter on the stage 3, and that's probably because of patients on stage 3 die earlier, and that's why their length of stay on the ICU is shorter. ICU length of stay and survival also. It was 7.3 on the non-AKI, around average 7 days, 8 days on the stage 2, 1.6 on the stage 3. Hospital length of stay also. Mechanical ventilations, again, is higher on the group, no AKI, stage 1, stage 2, shorter on the stage 3 for the same reason, I think. A tracheostomy was 40% of the stage 3 were tracheostomized, less on the stage 2 and stage 1. 15% of the no AKI were tracheostomized. Renal replacement therapy also highest among the stage 3. We did not know the timing of the RRT initiation, so we don't know when was the RRT started, and that's one of our limitation, that we could not include it in the definition of KDIGO criteria. And lastly, the predictors of hospital mortality. Again, stage 1 versus no AKI, stages versus no AKI, age were significant. Male sex are more prone to have to develop AKI. Apache score for every 10 unit increase, also bilirubin, lactic acid, and high INR also shared with higher chance of having AKI and in-hospital mortality. And then lastly, on the discussion part, I summarized what I found. I compared it with the other studies, which is a few studies that focusing on the subgroup, I mean the ventilated CAP patients. So I compared it with the bigger group, all hospital, and that's why we have a higher mortality compared to the other studies. The other studies ranging from 20 to 30, where we have like around 50% of mortality. I also spoke about the hypoxemia, and it's related to induced kidney injury. And there was several limitations of our study. It was a single center retrospective study. And second, the baseline creatinine was back calculation of baseline creatinine using the MDRD formula. And as I mentioned earlier, that we could not identify the timing of RRT initiation, so it was not involved in the KDIGO criteria. I hope I summarized most of it.
Excellent presentation, Dr. Majid. Comments open for discussion. Great. It's a big study for this type of patient, showing how renal acute kidney injury is important. I mean, it's in most prognostic factors of CAB. Kidney injury is there, so you should mention this also.
Yeah.
But in the CRP and most of the prognostic factors, kidney injury is a major risk factor. Dr. Saleh, تفضل عفوا.
Yeah, it's more common on elderly age and diabetic, and in our population, it's diabetes is very common.
Yeah.
Age is also, they think it's not a modifiable factor, but I think somehow it is modifiable factor.
Yeah, I mean, so diabetes is so common. So this explains the high High prevalence. So one thing that you need to clarify this study and the previous study. This is the AKI on admission. This prevalence of AKI on admission. But some patient did not have AKI early, but later required CRRT. Otherwise, it will be confusing to people. So this is on admission. So some patient did not have AKI and have AKI later. This is not captured here. Dr. Saleh.
I wonder, Prof, since we are discussing CAP, do you need to think about to correlate the causative organism, like some certain strains can induce a change. In this situation, predictor might be related to just to the patient received, different subjects rather than only CRRT like plasmapheresis or IV immunoglobulin, etc. So, is there any way to?
Yeah, I'm not sure if we can, but we'll discuss it with Dr. Musharraf if we can specify the pathogen, but I'm not sure.
It's a good point. I think we don't have this data, so I think it's important point to discuss in the discussion. So this is a good one to add to the discussion. Find from the literature relation with whether AKI differ by pathogen and whether having bacteremia. You could have bacteremia and not having bacteremia, صح? So in the but this data we don't have.
Sorry, kindly colleagues who are not speaking, there are some mics, can be muted, please.
Thank you, Dr. Hani. Next is Dr. Iman. A good point. This very good point, Dr. Saleh. I should address it, yeah, Majid. Iman, Dr. Iman.
Yes, thank you again, Dr. Abdul Majid. Very good study, but regarding the title, you are relating the acute kidney injury to community-acquired pneumonia. But I think it's more than pneumonia. It's going to severe sepsis, ARDS, because as you have mentioned, you have low PF ratio, you have liver enzymes affection, you have INR prolonged. So it's more like a sepsis disease, severe sepsis disease with acute kidney injury as well.
Yeah, but the primary insult was CAP, and that was an association. The ventilator itself, the sepsis and severe sepsis, multi-organ failures, that's a complication of the CAP. So yeah, I agree with you. It's systemic or multifactorial.
Yeah, I mean, every sepsis start with a localized, but now this study at this point, I think it's we can relate it to more inflammatory syndrome model to a community-acquired pneumonia.
It's true, but this is true, very true. But also, I think if you look at the prognostic factors of community-acquired pneumonia, almost all of them, acute kidney injury comes up. So in the community-acquired pneumonia literature, there are multiple prognostic factors. And these prognostic systems used to decide for admission to the hospital or not admission to the hospital, disposition in ICU or not, and acute kidney injury is part of it. But I agree with you, I think sepsis should be highlighted in the discussion as a little bit more clearer.
Yeah, sure.
Thank you. Good luck.
Thank you.
You're welcome. Thank you.
Any other comments, suggestions? I think the microbiology, the sepsis, good point to discuss.
Sure, yeah.
In the discussion. I think review of the literature for recent studies just make upset updated literature review to see if there are any new studies. I think you should also discuss the prognostic systems, like the I don't know what CRP. So there are multiple ones for community-acquired pneumonia. I think should at least mention them briefly in the discussion, and that kidney failure is part of it.
Right. Inshallah.
Prognostic, just address prognostic factors, prognostic systems.
Sure.
Very good. If there are no other comments, I like to thank all the presenters. Really great progress on these 3 studies. I think really coming along very nicely. All the comments today we had really fantastic and will help the residents moving their projects forward. And thank you all for your attendance, and have a good night.
Thank you.
Yalla, assalamu alaikum.